shall we start?
Yes, ma'am. But people are ready to join, ma'am. Like three,
Let
four.
them join as they come.
Yeah, fine. Like okay, ma'am. Yeah, we'll start, ma'am. Yeah.
Sure.
Satya.
Yes, sir.
Shall we start, ma'am?
Yes, sir. Yes, sir. I'm sharing, sir.
Yeah.
Sir, the host has to allow him, sir.
I'm the host, right? Or
Yes, sir.
okay, fine, right. Now what should be done, ma'am?
Sir, 1 second, sir. All right.
Satya, you are co-host. You can.
Okay, ma'am. Sir, my screen is visible, sir?
Not yet, Satya.
Yeah, the screen is not visible, ma'am.
1 second, sir. Is it visible, ma'am?
Yeah, it's visible, ma'am, but the slides are yet to open, ma'am.
Sir, is it visible now, sir?
No, the slides are not open, ma'am. But you're able to see, ma'am?
Sir, I'm sharing a link, sir.
No, only your mobile
WhatsApp-
screen is seen.
Okay, ma'am. 1 second.
Yeah.
That's visible, ma'am.
Yes, sir.
Shall we start, ma'am?
Sure.
Good evening, ma'am. Good evening, guys. Today we are going to discuss a case on brain death. Will be presented by Dr. Satya, Junior Consultant, Department of Critical Medicine, KMCH. Over to you, Satya.
Thank you, sir. So I'm going to present a case about brain death.
Satya, you can go for a full screen mode, ma'am.
Yes, sir.
In the bottom, you'll be having a display option, ma'am.
Yes, sir. 1 second, sir.
Okay, ma'am.
Yes, sir. 31 years old gentleman who is a farmer by occupation, who do not have any comorbidities and no habits, brought with a lead history of RTA road traffic accident on 29/11/2024 around 7 p.m. The mode of injury was when he was riding a two-wheeler without any helmet, hit by a lorry. The accident was followed by a loss of consciousness. He was initially got treated at an outside hospital where he was intubated and ventilated in view of low GCS, where the presenting GCS was E1, V2 and M5. And according to that discharge summary, he was hemodynamically stable and the pupils was about 3 millimeter sluggishly reacting to light. And immediately after intubation, the family got AMA discharge and brought to our hospital. On arrival to our emergency department, it was around 11 o'clock in the night. GCS was E1, VT, and M4. Bilateral pupils 3 mm sluggishly reacting to light, and hemodynamics were stable. Initial assessment was done. Primary survey, the airway was intubated with 8 mm internal diameter cuffed endotracheal tube, and the cervical collar was in place. Breathing, the patient had spontaneous respiratory efforts. He was on controlled ventilation, and respiratory rate was maintained in between 26 to 28. Circulation, heart rate 126 per minute, BP of 120/70, and EFAST was negative. Disability, the GCS presenting GCS was E1, VT, M4. The pupils 3 mm sluggishly reacting to light, and he didn't have any focal deficit.
What was the saturation, Satya? What was the ventilator requirements at that point of time?
Yes, sir. Sir, he was shifted with a transport ventilator. So immediately after connecting to our ventilator, the oxygenation was okay. SpO2 was maintaining about 98% with FiO2 of 40%, sir. And we kept him on volume control ventilation with a tidal volume of 360 with respiratory rate of 26 and ABG at to checking, sir.
Okay, okay, ma'am.
And secondary survey, the only positive finding was he had a suture wound of 6 centimeter over the right parietal area of the scalp. No other bone injuries and no other soft tissue injuries and bone injuries. And immediately 2 18-gauge peripheral cannula was secured and connected to normal saline drip, and a dose of 100 ml of 20% mannitol was given, and the patient was sedated and paralyzed and shifted for CT brain with cervical spine screening. The immediate CT, it showed a bilateral frontotemporoparietal thin SDH and diffuse SAH, diffuse cerebral edema with brainstem contusion. And the cervical spine was normal.
Apart from the any other findings, Satya?
Sir, the systems were effaced, sir. He
Okay,
had
ma'am.
a diffuse cerebral edema and no bone injuries in the cranium, sir.
Okay, is there any sulcigal differentiation, ma?
No, sir.
Okay, there was a diffuse edema, right?
Diffuse cerebral edema, sir. The edema was
Okay.
significant.
Okay, ma'am.
Yes, sir.
There was a SH as well, ma? Traumatic
Yes.
SH.
Yes, sir. He had
Long
diffuse SAH,
SH.
sir.
Okay, ma'am.
Yes, sir.
Okay, ma'am.
Yes,
How
sir.
about the C spine, ma?
So C spine was normal, sir. He didn't have any bone injury.
Okay, okay, ma'am.
Yes, sir. So the patient shifted to ICU and he was managed there. On day 1, he was managed with anti-edema measures. We started on 20% mannitol 100 ml Q8 hourly and 3% saline infusion of 30 ml per hour. And anti-epileptics, injection levetiracetam 500 mg IVBD, and he was sedated, paralyzed, and maintained with controlled ventilation. And ABG was monitored Q6 hourly, and the PCO2 was maintained in between 35 to 38. And the vitals were stable. On day 1, there was no vasopressor requirement. And blood investigations were done, and all the blood investigations were within the normal limits. And the sodium monitored 12th hourly, and it was 140 at 8 a.m. on day 1 and 148 in the evening.
What
And
was the osmolality, ma? Baseline, no?
sir, baseline serum osmolarity was 298, sir.
298, ma?
Yes, sir.
Okay, ma'am.
So ETCO2, coming to monitoring, we placed invasive lines, central line for giving drugs, anti-edema measures, and invasive arterial BP we monitored and connected to ETCO2 monitoring. And PaCO2 was maintained in between 35 to 38, so ETCO2 targeted accordingly. And BP was maintained in the normal range, sir. And normothermia we maintained. And
So why did you target ETCO2 specifically to 35 to 38, ma'am?
Sir, even hypercarbia and hypocarbia both causes a secondary brain injury. And hypercarbia leads to vasodilatation and increase in cerebral blood flow and increases ICP. And hypocarbia, it causes cerebral vasoconstriction and decreases the cerebral blood flow, and that even causes secondary brain damage. So generally we used to maintain 35 to 40, and in tire management, in refractory ICP cases, will even target lesser PaCO2 like 32 to 35.
Okay. Now, what are the interventions you have done? What are the goals of management this patient? So basically, you're dealing with a young chap with a severe TBA, right?
Yes, sir.
Isolated
Severe
severe
trauma.
TBA, right?
Yes, sir.
No other extracranial injury.
No other extracranial injuries, sir. Isolated traumatic brain injury.
And your CT and your clinical presentation is suggestive of raised intracranial pressure, Lama.
Yes, sir.
Okay. Now, what are the measures you do to prevent further worsening, ma?
Yes,
Now,
sir.
how are you going to monitor this patient? And
Yes,
what are
sir.
the interventions you're going to do?
Yes, sir. My goal of management is to prevent secondary brain injury and reduce ICP, sir.
What do you mean by
As
secondary brain injury, ma?
secondary brain injury, it is not caused by the direct traumatic injury itself, but after the traumatic brain injury, because of multiple reasons, it can happen, sir. It may be because of electrolyte disturbances and variations in PCO2 or PaO2, temperature measurements, and fluctuations in hemodynamic status. Anything can cause secondary brain damage.
No, all
So,
those things will aggravate the secondary brain injury, ma. So basically, following a primary brain injury, a
yes, sir.
cascade of events happens, ma. Right?
Yes, sir.
Okay. Inflammatory as well as some at the molecular level, a cascade of events happens that eventually worsens the existing primary brain injury. Now, our goal is to prevent the worsening of secondary brain injury, prevent it happening, if not primarily get it to prevent the worsening of secondary brain injury. So all the factors what you said right now, right? Now, hypoxia, hypocarbia, temperatures, hypothermia, extremes of sugars. Now, all these things will worsen your secondary brain injury. Right?
Yes,
Okay.
sir. Yes, sir.
Okay, ma.
So
So
the
you
goal
want
is
to
to,
prevent your secondary brain injury, right? Okay.
yes, sir, and to reduce ICP.
Okay.
If it is better to monitor ICP in a patient like severe traumatic brain injury, but as we don't have ICP monitoring, we'll follow with the other tire managements and other monitoring will do, sir.
Normal ICP, ma?
Sir, it should be maintained between, it should be maintained less than 12, sir. Sorry, less than 20. Any ICP more than 22 for more than sustained increase more than 15 minutes, it's a raised ICP. We have to reduce, sir. We have to take actions.
The normal ICP is 3 to 15, ma, but your target is less than 20.
20, sir.
And your CPP target, ma?
60 to 70, sir.
The basic idea of monitoring ICP is?
To maintain the CPP between 60 to 70.
No, which is a surrogate of?
Surrogate of ICP, sir. So MAP is equal to cerebral perfusion pressure minus ICP.
You need to monitor the cerebral blood flow, ma. We don't have any parameters right now to directly monitor the cerebral blood flow.
Okay, sir. Okay, sir.
So indirectly, we monitor the surrogate, which is a CPP. CPP is the difference of?
MAP minus ICP, sir.
So for that purpose, we monitor ICP, right? Okay.
Yes, sir.
Right, okay. The CPP target is?
60 to 70, sir.
60 to 70. Right, okay, ma. Fine, right, okay.
Yes, sir.
What neuromonitoring you did for this patient, ma?
Sir, as we don't have ICP monitoring, we used to monitor the ICP with non-invasive measures like ONSD and transcranial Doppler, sir.
Is it well validated, ma, in TBI patients?
Yes,
Do the
sir.
guidelines advocate use of transcranial Doppler, ma, for monitoring ICP and for
Sir,
monitoring?
yes, sir. It has a sensitivity and specificity of 90%. If we combine TCD, ONSD, and pupillometry, it will increases the specificity of detecting ICP. Yes, sir.
No, in the absence of invasive ICP monitoring, you have taken a surrogates, right?
Yes, sir.
Okay. So you are monitoring serially, ma?
Yes, sir.
How
In
serially you are monitoring your ONSD?
ONSD, every 6 to 8 hourly we are monitoring, sir. In every shift we are used to measure. And whenever there is change in pupillary sizes or fluctuation in GCS or any focal deficit, in that time also we'll do, sir.
Okay. So any changes from the baseline GCS, you do it. Apart from that, you do it 6th hourly.
Yes, sir.
Okay. So what was the baseline ONST for this patient with that CT, ma'am?
Sir, on day 1, it was around 0.72 on the right and 0.75 on the left, sir. It was raised only, sir.
You take a single reading or you take an average of?
Sir,
What do
it
you
has
do?
more subjective variation. It's better to have a average of 2 to 3 values.
Okay, ma'am, you have to take an average of 3 readings at least, right? Okay.
Yes, sir. Yes, sir.
Fine, right. So your baseline was 0.7, man,
Yes, sir.
bilateral.
Yes, sir.
Okay. So what are the measures you have taken to reduce the ICP, ma'am?
Sir, we followed a tire management, sir.
Okay.
So already the patient was intubated. So we maintained 40-degree head depth and head was in the neutral position. We placed all the invasive lines and hemodynamics were maintained, sir. We on day 1 we kept the patient under sedation relaxant, sedated paralyzed, and PCO2 was maintained between 32 to 35, and antiepileptics were continued, sir.
You reduce the ETCO2 to 30, ma'am.
Sir, we maintained a goal of PCO2 goal of 32 to 35, sir. Because considering this diffuse cerebral edema, we started on higher side only, sir.
You voluntarily hyperventilated, right? Mild
Yes, sir.
hyperventilation. You targeted a PSCO of 30.
Yes, sir. Around 32 to 35, sir.
Okay.
Usually in tier 3, it will come by around 32 to 35, sir. But here, considering the young age and severe cerebral edema, we started doing hyperventilation, sir.
Fine, right, ma'am. Okay, with these interventions, what was the response, ma'am?
Sir, on day 1, ONSD was maintaining in that range only, sir. We monitored with ONSD and this one only. So first day we sedated, paralyzed, and continued with all the neuroprotective measures.
Okay.
And on day 2, we took a CT brain, sir.
Okay.
For follow-up CT brain after nearly 12 hours. It showed no interval changes, sir. And we stopped the relaxant and assessed GCS. It was M1 response. And day 2, pupils become 3 NR.
Okay.
And there so neuroprotective measures continued, and we continued paralysis, and we targeted a sodium of 155 to 160 and osmolarity of 320. So we continued anti-edema measures, sir.
What's the target sodium? What's the target osmolarity, ma'am, with hyperosmolar therapy?
Sodium of 155 to 116, sir, and osmolarity is 320. And if we are using mannitol, we can accept a osmolar gap up to 20, sir. Maximum 20.
So you gave a combination of osmotherapy, right? For
Yes,
this
sir.
patient.
Yes, sir.
So now among this, which is better, mannitol versus 3% saline?
Sir, pertaining to this case, I don't have any
No,
evidence
generally
to
I'm
say
asking.
one.
What is the
Generally,
literature evidence? Yeah.
yes, sir. Generally,
Like
hypertonic saline is
like-
better compared to 3%, compared to mannitol, sir. And there are specific advantages and disadvantages with each one, sir.
What are the advantages and disadvantages, ma'am?
Mannitol, we have to be very cautious in patients with hypotension and acute kidney injury, sir. And we don't need a central line to administer mannitol. But in hypertonic saline, there is a risk of volume overload because of the higher osmolarity. But we need a central line for administration. But it can be safely given in hypotension and
What is the osmolarity of mannitol and 3% saline?
sir, for mannitol, it is around 1100, sir.
Okay, 1000.
1096. And hypertonic saline, it is a little higher than mannitol, sir.
Okay, 1026, ma'am.
Okay, sir.
Okay. No, both are almost in terms of osmolality, it is almost equivalent.
Yes, sir.
No, as I said, like in hypovolemic situations, mantle causes it can precipitate, it can worsen your hypovolemia. So somebody
Yes, sir.
TBI with a shock, obviously, we don't give a mannitol.
Yes,
Okay.
sir. Yes, sir.
Okay, ma'am. Fine, please continue. Sorry.
Sir, on day 2, neuroprotective measures continued and serial sodium monitoring done, sir. Sodium, it increased to 157 with osmolarity of 324 and osmolar gap was 10.
Okay.
So we continued both mannitol and hypertonic saline, sir.
So people have become 3 SR to NR, right?
Yes, sir.
And the GCS has dropped further, right? Right now it is M1 response.
Yes, sir.
But the CT taken on day 2, it was in the early morning, Amma.
Yes, sir. Early morning seating, sir.
That CT, there was not much of change compared to the first CT.
Yes, sir. Initial CT was done around 11 p.m. in the night, sir. And
Okay.
morning CT around 6 to 7 a.m. And no much changes, sir. Even the first CT had diffuse cerebral edema with almost sulci air, everything effaced, sir. Substance compressed. So even second CT had the same changes, sir.
What should be the minimal interval, no, to do a repeat scan?
Sir, in TBI and intracranial hemorrhage, it is better to do the risk of rebleeding or increase in hematoma expansion is more higher in the initial 6 to 8 hours, sir. So it is better to repeat the CT in the first 6 to 12 hours. Or if the patient is conscious, if there is any changes in the baseline GCS or pupillary changes, we have to proceed with the follow-up CT, sir.
When you drop in GCs by 2, you will better our cities.
If you anticipate a drastic change, then the frequency should be a bit more frequent, man, rather than waiting for 6 hours. On the other hand, if you don't anticipate any changes, then probably you can do it at 6 hours in the second CT. Right? Okay. Now, this patient CT was taken at 5 a.m., did not show any change. By evening 5 p.m., there was a drop in sensor, right?
Sir, morning
Nothing
around,
to-
yeah, we stopped relaxant in the at 8 a.m., sir. So,
What relaxant was the patient was on, ma'am?
sir, he was on fentanyl, 50 mg per hour infusion and atracurium, sir.
Okay.
Atracurium 30 mg per
LFTs and
hour.
RFTs are normal, right? He had a normal
Yes.
renal liver function, right?
Yes, sir.
So should not take for him too much to come out of relaxant.
Yes, sir. Yes, sir.
So this GCS with the motor response M1 was assessed at what time, ma'am?
8 o'clock we stopped relaxant, sir. So this disease was assessed by 9:30 to 10, sir.
Okay.
After that, we again paralyzed him.
Did not do repeat any CT, ma'am?
Sir, after that second CT only, we assessed GCS, sir.
Oh, after the M1 response only, you done a CT.
Morning 5 o'clock we did a CT and after that only we assessed GCS, sir.
Okay, ma'am. Now the GCS is low, right? M1 response, right?
Yes, sir.
So that was at 9:30 a.m., right? But the CT
Yes,
was
sir.
done at 5 a.m., right?
Yes, sir.
And people have become 3 NR, right?
Yes, sir.
ONSD, ma'am, how was the trend of ONSD?
Sir, ONSG was increasing only, sir. On the right side, it is 0.8 centimeters, and on the left, it is 0.82 centimeters, sir.
Okay. ONSD below how many millimeters, ma? It is suggestive of raised ICP.
Sir, more than 0.6 indicates raised ICP, sir.
Like 0.7. Okay. So is there any? It reflects how much amount of ICP, ma? Above 5.7.
I'm not sure exactly, but maybe it indicates raised ICP. It may be more than 22, sir.
About 20, ma. Is there a
Okay.
linear correlation with the rise in OSD and rise in ICP, ma?
Yes, sir. Serial ONSD monitoring will correlate with the rise in ICP, sir.
Till what level of ONSD, ma?
Oh, ONSD value you're asking, sir?
Yeah. No, beyond 7.5, it plateaus, man.
Okay, sir.
There is no further rise in ONSD, right? Okay.
Okay, sir.
So more than 5.5 or 5.7, the upper limit of normal is 5 for children and adults, right? Okay.
Okay,
So
sir.
5.5, it's more subjective variability. You have to do it appropriately, properly. You have to take average of 3 readings. Okay.
Okay, sir.
If it is consistently above 5.5, it indicates rise ICP above 20. Now, despite all your medical interventions to reduce the ICP, but still your ICP is rising, right, for this patient.
Yes, sir.
Now, what interventions have you done further? You've done sedation relaxant, you've done head up elevation, you've done osmotherapy, you already touched the brim, 320 of osmolarity.
Yes, sir.
If the osmolar cap is 10, you can slightly go on the higher side. What
Yes,
else
sir.
can be done?
Sir, if the according to tire management, if the ICP monitoring is there, we can do a MAP challenge and assess cerebral autoregulation, and accordingly we can increase the MAP, sir, to increase cerebral perfusion pressure, and we can do barbiturate coma also if there is ICP monitoring, sir. And if there is EVD in situ, we can proceed with CSF drainage. But for my case, as there is no invasive monitoring, we just continued with the maximum neuroprotective
Repeat
measures.
the CT scan, huh?
Sir?
No, have you not repeat the CT scan?
Sir, after that 9 a.m. we didn't repeat, sir. Next day only we repeated.
No, Satya, if all your medical management is saturated, what is the next option?
Ma'am,
Any
we
surgical
can go ahead
intervention?
with the decompressive craniectomy, but for this patient, there is no drainable lesions like SDH or EDH. It's only
Yeah,
this is
so
What is
refractory raised ICP, what is the surgical management?
yes, ma'am.
What is
what
it?
is second?
We
What
can
is
proceed.
it?
We can proceed with the decompressive craniectomy, ma'am.
What
Sir,
decompressive craniectomy?
bifrontal, bilateral
Yeah,
frontotemporal
by
decompressive
frontotemporal we can do, yes.
yes, ma'am. Frontotemporal decompressive craniectomy, but neurosurgeon didn't agree with that.
Young chap, man, should have convinced him, right?
Yes, sir.
Okay. Now, what is the evidence for the secondary? What do you mean primary decompressive craniectomy and the secondary decompressive craniectomy?
So primary decompressive craniectomy at the time of based on the first CT itself, as a initial management, we are proceeding with decompression, sir. And secondary decompression after.
When there is a surgical evacuable lesion,
Yes, sir.
when you do that surgically evacuable lesion, which is causing a mass of it, along with that, you do a decompressive craniectomy, right?
Yes, sir.
This case is going to have a worsening ICP.
Yes, sir.
That is called as a primary decompressive craniectomy. On the other hand, as Madam told, now when the ICP management, when you're burnt out all your medical management, you're doing the max, right? And despite
Yes,
that, your ICP is still high, persistent. There you consider getting a secondary decompressive craniectomy, right? Okay.
Yes, sir. Yes, sir.
So what should the minimal dimension of the flap that should be taken out, no?
So 12 cross 15 centimeters, sir.
No, okay.
Sorry to interrupt. I think we are deviating from the topic. We've not yet touched brain death.
Oh, fine. It. Okay, ma'am. Fine, right now. We proceed that get okay, we proceed, ma'am.
Yes, sir. So on day 3, with the continuing neuroprotective measures, the patient became polyuric. Urine output was 200 ml per hour, and the sodium was climbing. It was 160. And we stopped hypertonic saline and mannitol, and IV fluid was changed from NS to 5% dextrose because of the polyuria. And we started vasopressin infusion, 1 unit per hour infusions. And we stopped sedation relaxant. Vital was stable, and we took a repeat CT at that time, sir. And CT brain showed worsening of cerebral edema, and there is no sulci-gyre differentiation. And almost the brainstem contusion and the bleeding were almost in the same range, but the cerebral edema was increasing.
Okay.
And after after 3 hours of neuromuscular paralysis, we again assessed, and the vitals were stable, sir. Pupils 3 mm not reacting to light, and brainstem reflexes were absent. We checked pupillary reflex, corneal reflex and cough reflex, all were absent, and also a movement of absent. And we did a TCD, showed a reversal of flow, sir.
So Satya, at this juncture,
Yes,
how
ma'am.
does TCD help you?
TCD, we can see the trend of for a ICP. We can monitor ICP, ma'am, by
No, no,
assessing.
no. You were, as of now, you were
Oh, this case you're
treating the
asking. Okay.
patient with the aim of reducing the ICP.
Yes, ma'am.
From here, you move on to concept of brain death declaration and future possibility of organ
Yes.
preservation.
Yes, ma'am.
So switching from treatment to conservation of the organs, how does that decision making help you? Like you said, clinical signs of urine output and raising sodium, but you were very recently on mannitol, and then you moved on to dextrose containing IV fluids, which could lead to hyperglycemia. So urine output may not be diabetes insipidus. It could be because of other causes. And
Yes,
you were
ma'am.
on 3%, which could be attributed to the sodium. So how can you justify that the patient is going into brain death and switch over your treatment?
Ma'am, not only based on the urine output, ma'am, we assessed brainstem reflexes, it were absent only, ma'am.
How many hours post stopping of relaxant?
Ma'am, we assessed 3 hours after stopping the relaxant. Generally,
May not be sure, no?
okay, ma'am.
Basically, what I want to do, what I want to say is you were correct in using the TCD. This waveform is very much corroborative with uh, brain death. It's not called brain death, it is called cerebral circulatory arrest.
Yes, ma'am.
It is very much correlating with that. Once you see this, but you have to, this mode of investigation is not helpful in declaration of brain death, at
Yes,
least in
ma'am.
India.
Yes, ma'am.
But for switching your treatment mode, this is very suggestive. So you stop your antipyretics, you stop your antiepileptics, anti-edema measures, and go towards organ preservation.
Yes, ma'am.
Okay.
Yes, ma'am.
Yeah, continue.
So, as we were explaining the Goddard prognosis since the time of admission, considering the severity of the brain injury, after the brainstem dysfunction, once again family counseled regarding the critical nature of the illness, brainstem dysfunction, and further risk of other organ dysfunctions and mortality has been explained. And as the family initiated, not exactly family, ma'am, the relative initiated the option of organ donation. We explained the details regarding organ donation also.
But is this the right time to talk about organ donation, Satya? No, not completely confirmed brain death, right?
Yes, sir. Sir, we explained like there is a high possibility as we are seeing more signs of brainstem dysfunction. There is a
No,
high
but throughout
probability
the
of.
course of the presentation of this patient, no,
Yes.
were you like discussing the criticalness of the situation, the trend, like despite all your medical measures, the ICP was refractory.
Yes,
The
sir.
family was aware like the patient's not doing well, and the expected course.
Yes, sir. We are updating the family every 8th hour, sir. And since the time of admission, we are explaining Goddard prognosis on link, sir. Available options of available treatment options and the risk of further deterioration. Everything explained, well explained, sir.
Probably you can prognosticate, man, there is no doubt, from the existing information what you have clinically, from your image, and from your lab parameters. Now, obviously, the attendant is not happy, sure.
Yes, sir.
But though the attendants might spell out the possibility for organ donation, but I think it's too early. Probably you can tell them, you can prognosticate them. Probably you can tell them once it's been confirmed, then probably we'll take it from there, right?
Yes, sir. Sir, we didn't
So,
initiate that. Yes.
Satya, what was your reply to family when they said the possibility for organ donation?
Ma'am, I can't understand, ma'am. perspective of family towards organ donation you're
No,
asking, ma'am?
yeah, so they have upfront asked you for organ donation when you are saying that patient is not doing well and there is a possibility of brain death. So
Yes.
what reply did you give? What did you tell them?
We are yet to confirm brain death. There are some tests available to confirm the brain death. After that only we can say that whether the patient is fit for organ donation like that. I explained, ma'am.
Exactly. That is what Dr. Gopi was asking me. So
Yes,
how
ma'am.
do you confirm? How do you define brain death? Because your exam going, what is the definition of brain death?
It is a irreversible cessation of all the brain activities, cerebral and brainstem activities, ma'am.
No. Exact definition. Irreversible is correct. Then the 3 C's have to come, no?
Unresponsiveness, coma,
Mhm.
apnea, and areflexia, ma'am.
Correct. So all 3 have to be there and it has to be irreversible.
Yes, ma'am.
And how did you confirm organ brain death, sorry?
We can proceed with the apnea test, ma'am. If there is
So you
no
tell
other
me apnea test.
What are the confounders, ma'am, before you jump onto it? Now, what is the first step like?
Yes, sir.
What are
We
the
can-
prerequisites?
Yes, sir. Yes, sir. First, if the patient is having absence of brainstem reflexes and other 3 signs, areflexia and apnea and unresponsiveness, and at that time we have to rule out other confounders for brainstem dysfunction, sir, like hypothermia, severe electrolyte disturbances, and other injuries like drugs, and other injuries like high cervical spine injury, and other causes of neuromuscular paralysis like GBS. Everything we have to rule out. If everything, every other cause is ruled out, and we have to think about apnea test. For that, we have to stabilize. We have to assess whether we can proceed for apnea test. Before
Wait.
proceeding,
How do you rule out any drug related cause?
based on the history, we can suspect if the patient is admitted with deliberate self-harm or drug overdose, we have to wait for nearly 3 days, ma'am. 3 to 5 days. And
What is 3 to 5 days? That is not the answer.
any
So
drug
it
we
is
have to wait for.
alcohol intoxication. You know the etiology. How long do you have to wait?
If for any drug, 4 to 5 half-life, we have to wait, ma'am.
Yeah, 5 half-lives. It's
Yes,
not
ma'am.
days. Depends upon the drug. 5
Unknown.
half-lives you have to wait.
Yes, ma'am. If it is an unknown drug, we have to wait for 3 days.
Correct.
This patient is
And if it is hypothermia?
we have to correct hypothermia first. We have to bring the temperature between 32 to 36 to 37. And we have to correct electrolyte disturbances. And we have to correct acid-base disturbances. And the
After correction, how long do you wait?
Post hypothermia.
post hypothermia you're asking, ma'am.
Yeah.
Usually we'll wait 72 hours. In case of post cardiac arrest induced hypothermia, we'll wait 72 hours after rewarming.
After achieving normothermia.
Yes, sir.
Why is that specific
Then?
time? Man?
Uh,
How does hypothermia influences? What does it do?
the severe hypothermia, even that can cause coma. Brainstem dysfunctions.
But you rewarmed, right? You have brought to normal temperature, right?
Yes, sir.
But after bringing to normal temperature, you wait for normothermia, you wait for 72 hours, right?
Sir. Yes, sir. Sir, I don't know. Why exactly 72 hours, I don't know, sir.
Varun? Varun, are you there, man? No, anybody else can answer, man?
Yes, sir. I'm here, sir.
Varun?
Yes, sir.
No, like post cardiac arrest, you give
Yes, sir.
treatment, right?
Yes, sir.
Now, after that, you rewarm the patient to normothermia.
Yes, sir.
Satya says you have to wait 72 hours post achieving normothermia before
Yes,
you
sir.
start prognostication, before you start working up for brain death.
Okay, sir.
Now, why should you wait for 72 hours, man?
Should wait for the
Anybody else can answer?
The inflammatory response as well as the
No, hypothermia. In normal LFT and RFT, the hypothermia per se will prolong your PKPD of all your drugs, man. So for
Okay.
the patient to come out of sedation, come out of relaxation, it takes a longer time,
okay, sir.
right? Okay. So you have to leave sufficient time, at least 72 hours, right? Okay.
Okay, sir.
Okay, ma'am.
So prerequisite we have to maintain normothermia, normal electrolyte and acid base status. After that only we have to think about apnea test.
After that, after rolling out all the confounders, only you have to evaluate the brainstem reflexes.
Yes, sir.
The first and foremost step is you have to demonstrate the presence of irreversible coma. The cause for the irreversible coma should be objectively demonstrated.
Yes, sir.
Then you have to rule out all the confounding factors, as I said. In the absence of all the confounding factors, only then you have to move on to evaluate brainstem reflexes. Okay.
Yes, sir. Yes, sir.
What do you do in brainstem reflexes? Why do you evaluate brainstem reflexes, ma?
Sir, absence of brainstem reflexes only we can diagnose brain dead, sir.
Varun? Varun, are you there, man?
Sir, I'm there. Just thinking it.
No, you're indirectly trying to prove that the brainstem is completely irreversibly damaged.
Okay.
To assess the irreversible damage of brainstem, you are assessing the brainstem reflexes, right? Okay.
Okay, sir.
So what are the reflexes you evaluate, man?
Sir, pupillary reflex and corneal reflex, cough reflex, a cold caloric test, and oculocephalic reflex, dorsal eye movement, sir.
Okay.
That's it.
Explain each test. How do you perform?
Pupillary reflex, it is mediated by second and third cranial nerve. It is assessed by flashing the light. And corneal reflex using a wisp of cotton. we have to-
What pupillary size?
It may be between 2 to 3, and it should be briskly reacting to light. And in brainstem reflexes, mostly it will be in the mid position, ma'am. And
So position is not required. Fixed and dilated is all you need.
yes, ma'am.
Okay.
Yes.
Mid size is not required to declare a brain death. Size doesn't matter. It should be fixed and dilated.
Okay, ma'am. Okay, ma'am. And corneal reflex, we have to use a wisp of cotton and touch at the corneal conjunctival junction, sclerocorneal junction. And brisk eye closure is the reflex, eyelid closure, and it is mediated by 5 and 7th cranial nerve. And cough reflex, it is we can use the
No,
cotton-
no. Go head to toe, man. You're on the eye. Finish all the eye reflexes. Doll's eye.
yes, ma'am. Doll's eye, before doing doll's eye, we have to rule out C-spine injury generally, and we have to move the head sideways. Usually, the eyes will be moved towards the opposite to the side of movement. In case of brainstem dysfunction, it will be fixed. There should not be any movement of the eyeball.
Why is it called doll's eye?
It is mimicking the movement of the doll.
So what is the normal reaction?
The movement of the eyeball will be opposite to the side of movement, ma'am, normally.
Yeah, the
There will be conjugate
corrective
deviation, which will be not, which will be absent, ma'am.
in brain death, it will be absent. In
Yes,
a
ma'am.
normal intact reflex, it would be in the opposite direction of the
Movement of
head turning.
Yes,
Okay,
ma'am.
ma'am.
For the doll, it will be towards the same side.
Okay,
Okay,
ma'am.
continue.
And cold caloric test, we have to use cold saline, nearly 50 ml of
Requisite.
we have to check
Ruptured eardrum. We should rule out ruptured eardrum.
tympanic
Yes.
membrane should be intact, and after that we can
Yes.
proceed with cold
What
drop.
position? Head position?
Head should be in the neutral position, ma'am.
30-degree elevation should be there.
Why is it needed?
Because then only the lateral semicircular canal will be in vertical position. The results will be better. Results will be seen.
Correct. Continue.
So normal response will be the eyes will be moving to the opposite side with the cold saline, and towards the same side with warm saline. And here in brainstem dysfunction, the movement will be absent.
Which movement responds to that causal? Which movement of the eye corresponds to that mnemonic?
Same side eye, ma'am.
Fast nystagmus.
No. Correct. So when you move, there is one slow movement along the side of the motion, and there is a fast corrective movement. So this mnemonic is for the fast nystagmus movement that should occur.
Okay, ma'am. Okay.
Okay.
That's it, ma'am.
Now, how much you
9th and 10th?
Cough reflex.
Cough reflex. You can use a cotton swab to touch the posterior pharyngeal wall. There will be a reflex cough or gag. It is mediated by
how much time of gap should be given before you examine the other ear for cold caloric test?
At least 30 minutes to 1 hour.
Hey, we'll never finish the brain death, man.
5 minutes is enough, da.
Okay, 5 minutes. Okay.
Why is it needed?
The nystagmus has to settle.
No. If the eighth nerve center is intact, the effect of the first injection will cause giddiness and vomiting nausea sensation. And if it's done immediately, before the effect of the first injection is cleared, you inject on the other side, the two might get summated. The effect will be increased. You won't be able to appreciate each side separately. That's why you have to give 5 minutes gap so that the effect of the first injection is completely worn off before you induce another.
Okay, ma'am.
Continue.
So we just finished brainstem reflexes, ma'am.
Yeah. Then
You told cough gag reflex, lama?
Yes, sir.
Okay.
talk about apnea.
Yes, ma'am. Apnea test, after ruling out all the confounders and all the requisites we have to check. After that, we can proceed with apnea testing. For that, we have to
Why is
pre-oxygenate.
the apnea test done last?
Ma'am,
Why apnea?
Why is the apnea test done last?
it is the confirmation of brain dead.
Others also.
Ma'am, after there is a risk of hypoxia and hemodynamic instability, ma'am. Only if the suspicion of brainstem dysfunction, like brainstem reflexes are absent, in that case, we have to proceed with apnea test.
Correct. Your answer should be the apnea test is quite devastating. If the patient is actually not brain dead, you may induce hypotension and hypoxia, which could be detrimental. It is not a confirmatory test. Confirmatory tests are the other ancillary tests. Okay.
Yes, ma'am.
All the three things, presence of coma, brainstem reflexes, and apnea, all three are equally important for brain dead declaration. It's not that apnea test done is enough. All three have to be carried out. But
Yes,
because apnea is so devastating to the hemodynamics, that's why it is done last. Okay.
Okay, ma'am.
Continue.
So we'll pre-oxygenate with 100% O2 for 10 minutes.
What should
And
be the systolic BP target, man, before you start apnea testing?
Sir, it should be-
The target.
It should be more than
More
90.
than 100 millimeters of mercury. 100.
What is the rule of hundreds?
The
Systolic-
systolic
systolic
BP
BP
should be Systolic BP should be more than 100 millimeters of mercury, and the hemoglobin should be more than 100 milligrams, 10 grams.
10 grams per deciliter.
And glucose should be more than 100 grams, and PO2
Saturation should be 100.
saturation 100, PO2 should be more than 100.
Mm. So what are the prerequisites you said? These should be there. How do you actually do the test?
Core temperature should be more than 36. Systolic BP should be more than 100. Patient should be eucapnic and euvolumic should be there, and there shouldn't be any hypoxia, ma'am. These will be the prerequisites.
Okay, ma'am.
Once this is done, we'll pre-oxygenate the patient with 100% oxygen for at least 5 to 8 minutes or 10 minutes. Disconnect the ETT from the ventilator and inserting a
You have to titrate your ventilator settings, get your gas done, and
get a baseline ABG,
Yeah.
and then insufflate oxygen via
Oh, wait. What is your baseline AVG target? Why are you, Gopi said you're going to titrate the ventilation. What are you titrating? What is the aim of titration? I mean, what is the limit of titration?
The baseline PCO2 should be 40 to 45, ma'am, not more than that.
What?
And the
Why?
pH should be close to normal range. If it is
No,
not,
why
it
are
should
you
not be less
bringing
than
that?
7.3.
You were keeping your target of the 32 to 35 when you were treating the patient. That's how your ventilator was set. Now,
Yes,
why are
ma'am.
you increasing the CO2 to 45? Simple logic, man.
Ma'am, only if
The
PCO2 increases.
of
not-
disconnection has to be brought down
Okay.
because you have to raise the CO2 to 60. If you have a baseline higher, you have to you disconnect the ventilator for that much less time. That's the only
Okay.
reason.
Okay.
Continue.
So we'll take a baseline ABG and check the baseline values and disconnect the ventilator and insert a catheter through the ETT till the carina, and we'll administer 2 to 6 liters of O2 through that. And
So your patient had a lung injury as well. He was requiring a high PEEP. With this mode of apnea testing, will you ever succeed in doing an apnea test?
if the patient is severely hemodynamically unstable, requiring high vasopressor support or high PEEP,
Not vasopressor, PEEP.
high PEEP or high FiO2 requirement, in that case, we can't proceed with apnea test, ma'am.
No, there is a modification. What is a modified apnea test?
We can connect to TPs, that's another method, but it won't.
Not TPs, something else. Connect to Bain circuit, no.
Okay, ma'am.
You can provide the PEEP so that the hypoxia and desaturation is less. And you
Okay.
can give the PEEP. And at the same time, you can have by palpation, you can feel for any air exchange as well as visually you can see for any uplift.
Okay, ma'am.
You have additional benefit.
Okay, ma'am. Okay,
The other
ma'am.
thing, you have to raise your sensitivity of your flow. If it's a flow trigger, you have to change to pressure trigger and raise the sensitivity. Sometimes there can be if you keep the sensitivity too less, then probably even a small movement can trigger the ventilator. It might give a false negative results.
Okay, sir. So we'll observe for 10 to 15 minutes for any chest wall movement or any other movements. And then
10 to 15 minutes. No.
Within the
8 to 10 minutes.
10 minutes.
8 to 10 minutes. Okay. So we'll check
So
ABG.
what are the small cheatings that you can do to prevent any of the cutoffs that you said? Saturation shouldn't fall, BP shouldn't fall. So to prevent all these mishaps, before starting the test, what all will you measures will you undertake?
We'll give fluid boluses.
Yes. Why are you giving that?
Maintaining euvolemia can prevent early hypotension, ma'am.
Yes. Basically, when CO2 is going to build up, there is going to be vasodilatation.
Yes, ma'am.
Build up volume, and you also keep a rushing pint, fast running IV fluid to keep filling as the vasodilatation happens. That is one thing. And you can pre-procedure itself build up a higher map with an additional inotrope or go up on the existing dose of the inotrope. And make sure your DI is well controlled with vasopressin.
Okay, ma'am.
Continue.
So we'll at the end of 8 to 10 minutes, we'll check ABG. We'll look for rise in PCO2 from the baseline, 20 millimeters mercury from the baseline, or PCO2 of more than 60 millimeters of mercury, and the pH of 7.28 to 7.3. It
You
indicates
tell me exactly what all do you need? Either rise of
Drop
20 or 60.
drop in pH to 7.28.
Yeah, so you need both of it. This is the new criteria. The 2023 AN criteria says both should be present. Earlier, this pH thing was not necessary. Now you need both the categories. The CO2 ventilation has to raise the CO2 to 60 or from baseline to 20. So if the baseline was 30 and you've reached 50, that is acceptable. It doesn't have to touch 60 necessarily. So
Okay.
that becomes optional, but your pH has to drop to less than 7.3.
Okay.
That both these criteria has to be met.
Okay, ma'am.
Okay.
If after checking the ABG, if it is significantly raised, we can connect to the ventilator and we'll proceed with the preservation of organ functions.
So suppose your patient was on ECMO.
Okay, ma'am.
How will you proceed? Can you do a brain death at all on a patient on ECMO?
Yes, ma'am. It's better to proceed with the ancillary test.
No.
Can we raise the CO2, Satya, on a patient who is on ECMO? What controls the CO2?
Will reduce the sweep, sir.
Yeah. Now, how do you come down the sweep gas? How much to come down?
Sir, based on the baseline sweep level, we'll do ABG and titrate, sir.
Can you come down?
What is the minimum sweep level you'll need?
Minimum 1 liter at least needed, ma'am.
You can go down to 0.5. Or what else can you do? You can exogenously administer some amount of carbon dioxide.
Okay, ma'am.
Where do you take the sample?
Ma'am, maybe from the right radial.
Depends upon which mode you are on. VV or VA?
Yes,
VV
ma'am.
is easy. VA is difficult.
Yes, ma'am. In VA specifically, we have to go for right radial sample.
So where will your arterial line be?
It has to be on the. It has to be on the right radial, ma'am.
No. The VA systems, A is where right now to take a distal sample from radial artery.
Ma'am, I can understand, ma'am, your question.
Carotid femoral where? I think you have to read that
Okay.
somewhere.
Okay.
No?
VA, the femoral, the arterial line will be in the femoral, ma'am.
Correct.
So there is a risk of north-south syndrome. That's why we're opting for the right radial. Yes, ma'am.
So when do you repeat the test?
After 6 hours, ma'am.
Who can do? How many people should be involved?
5% should be there.
No. 5 persons should be there, right?
4%, ma'am.
Declaration of brain death.
Who are these 4 people?
The treating physician, the intensivist, and the
A
neurophysician.
neurologist or a neurosurgeon? And a
So
registered medical
basically for
practitioner.
Registered medical officer.
you have to do, just 1 second. You need 2 sets of tests to be done, right?
Yes,
For
ma'am.
each set of tests, there should be two investigators, 2 people carrying out the test. That's how you need 4 people. And the same 2 people cannot repeat both the sets.
Okay, ma'am.
First set is done by 2 people, second set is done by 2. That's why you require 4. Now, who are the ones who are eligible to do the test? Neurologists and neurosurgeons by virtue of their degree. The rest, who else can do? The treating physician shouldn't be no need. That MD medicine guy has no experience of doing brain death declaration. Why is he needed?
No, ma'am. This is intensivist, ma'am.
All intensivists are also not eligible. So board empaneled. Each hospital has to get board empaneled people. Now, who are the board empaneled? Could be anyone, even an physician can be board empaneled, provided they have had experience of doing it. Okay, so
Okay,
there are empanelment requirements are there, but once you're certified and you've been empaneled in that, you can carry out. That could be anyone, intensivist, physician, anybody. So 4 different people are needed and 6 hours apart. What is for the pediatric requirement? What should be the difference in time for the 2 sets of tests?
Ma'am, in neonates, we should wait for at least 12 hours. In children, 24 hours.
Ulta is it? Neonates 24 hours, children
Children,
12
24
hours.
hours and children, 12 hours, ma'am.
Then, yeah, so since this is only about brain death, I think you should stop here. Organ donation, I think, is next class. But in the certificate, this patient is asked for an organ donation, and suppose successfully organs are harvested from him. What is the time of death certification?
The first apnea time. The first apnea time.
Yes. Still
First apnea
controversy is
time.
going on.
Correct. Suppose they had refused, then
Ma'am, both will be the first apnea time, ma'am.
so this was your result, huh? What you're showing on the.
Yes, ma'am.
Okay. Yeah, open house. Anybody wants to ask anything, please go ahead.
Ancillary testing, should you have to discuss, ma'am? When to do?
Yeah, definitely,
Good.
definitely. So, Satya, you said the TCD, no? What are the TCD criteria for brain death?
Ma'am, reversal of flow, ma'am. Absent diastolic flow, there will be reversal of flow.
Mhm. Where all you have to
Yeah,
check?
high pulsatility index will be there, ma'am. And
No, pulsatility index is only for raised ICP, not for brain death declaration. Again, it should be called cerebral circulatory arrest, not brain death.
okay, ma'am. So it should be checked bilaterally. So the
Where
result
all?
bilaterally anterior and posterior, ma'am.
Correct. Bilateral, anterior circulation, posterior circulation. All 4 sites have to be tested if you're using an ancillary test to declare a brain death. When do you require ancillary test as a supportive measure for declaring?
When there is a contraindication or when the apnea test could not be done, like
Is apnea test everything? Yeah, you're harping on apnea test. What if his eyes are gone?
No, in that case only we'll proceed with the ancillary test, no, ma'am.
You clearly know.
Not on the apnea test.
Component.
When we are not able to elicit brainstem reflexes.
If both eyes are gone, both tympanic membranes are shattered,
Yes,
you
ma'am.
can't finish your brainstem reflexes.
Reflexes, yes, ma'am.
Apnea test is the commonest thing which fails. That's why people talk about. But if carried out properly, apnea test doesn't fail. It's more a human error than any other thing.
Okay, ma'am.
What are the ancillary tests? Other ancillary tests available?
Ma'am, EEG, transcranial Doppler, cerebral angiography, and nuclear scintigraphy, ma'am.
What should you see in EEG?
EEG, isoelectric EEG pattern will be there. It is a safe bedside test, but there will be, it is more prone for artifacts, ma'am. And it will test only the cortical functions. So there are many disadvantages with the EEG. If the patient was on sedation or hypothermia, it will all have artifacts.
Angiography?
Angiography, there will not be any filling of intracranial vessels.
Absence of cerebral circulation.
Correct. And scintigraphy?
Scintigraphy, there will be empty light bulb sign, ma'am. Absence of uptake in the.
Hollow skull sign.
Isotope will not be uptaken. Hollow skull phenomenon.
Hmm. Okay. So if you, so what is the difference between brain stem death and whole brain death? What do we need?
We need brainstem death, ma'am.
India.
Yes. US, you need whole brain death. What is the difference?
It will.
They require
the
both the
cortical
ancillary
function.
test as well as the apnea test to be confirmed. For us, either apnea test as well as the brainstem absence is enough, ma'am.
Arey, yaar, apnea test is the least important. We
Okay.
need clinical.
Clinical. Okay.
We need all three clinical findings, all sets of three clinical findings to say that the patient is brain dead. In US, you need it to be along presence of
Clinical ancillary test.
ancillary tests also.
Okay.
2 out of 3 ancillary tests should be available. But that is not what differentiates brainstem from brain death. Phylogenetically, the development of brain is from different parts. So the pituitary part of it, evolutionary wise, is different. So sometimes what happens, the patient may not go into DI, though you will have all clinical findings. Okay, all your clinical brainstem reflexes are absent, apnea test is present, the patient will not go into DI because you may have a small amount of preserved circulation in the pituitary area. So in India, that person is legally called brain dead, but in US, he will not be. You have to have every part of the brain completely stopped functioning, only then you can call.
Okay.
That is the difference.
Okay.
Gopi, anything we are leaving on?
Nothing, ma'am. Like, no, as I said, like, ancillary test generally, it's better to avoid as much as possible. If a clinical situation warrants, if there is no other option, then probably we need to select appropriate ancillary test. The problem with all the ancillary tests is none of the ancillary tests are ideal, ma'am.
Okay.
That is the biggest problem. Otherwise, okay, we cover the maximum.
Anybody needs to ask anything, please? Now is the time. Well done, Satya. Thank you, Dr. Gopi.
Thank
A
you.
Thank you.
very good
Thank
way to start our New Year classes. It is a good one. Thank you very much.
Thank you.
Thank you.
Thank you, sir.
I will soon put up the new list, excluding Satya and Varun, for the next set of classes.
Okay,
And
ma'am.
if we have any new candidates joining, I'll put them later on. With the existing ones, I have made a list I'll put on by tomorrow.
Okay, ma'am.
Thank you very much. Good night.
Thank you.
Thank you.
you.
Thank you. Good night, ma'am. Thank you.
Thank you, sir.
Thank you.
Thank you.
Bachelor.